So today topic is hematological management, and the speaker we have here is Dr. Varun Arora, who is a consultant at BLK Max Hospital, Delhi. Thank you, sir, for being with us.
Good evening, everyone. So I'll be discussing about hematological management, the questions which are usually asked in part 1 EDIC, both type A and type K questions. So I would request you that you can ask the questions later after this session or in the chat box. I will try to answer all your questions. So let's start. This hematological management part is more theoretical. You have to mug up certain numbers. You have to remember certain terminologies. Uh, I mean, more of theoretical part rather than practical. So let's start with blood transfusion. So in most critically ill patients, the transfusion trigger is 7 grams per deciliter, HB of 7 grams per deciliter. Below 7, you have to transfuse. Above 7, you are not supposed to transfuse. This is based on the trick and twist trials, the very famous trials, transfusion related in septic shock and in critical care. But in certain subset of patients, like the patients who are having coronary artery disease and acute coronary syndromes, you have to maintain a hemoglobin of 10 grams per deciliter. So below 10, you have to transfuse them slowly under Lasix cover. It has been shown that maintaining a transfusion trigger of 10 grams has got increased survival. So they specifically asked that is there any mortality benefit? So yes, the chances of survival increases if you maintain the hemoglobin target of 10. So each unit of PRBC, that is packed RBC, has got 300 to 400 ml of volume. You have to remember this. And one unit increases hemoglobin by 1 gram per deciliter and hematocrit by 3%. So 1:3 ratio in adult patient without any ongoing blood loss or any destruction. So if you transfuse one PRBC, your hemoglobin will roughly increase by 1. So if you transfuse 2, your hemoglobin will increase by 2 grams per deciliter. So they usually ask in specifically in type K questions. And in emergency situations, you can give O negative RBCs because O negative RBCs don't have any A, B, or Rh positive antigen. So you can safely transfuse this O negative RBCs in emergency situations. So what are the types of RBC products? Usually these days we don't give whole blood. We usually make the components of whole blood and transfuse. So whole blood has got all the components and only indication as of now, it is autologous donation prior to surgery, especially in certain rare types of blood group like Bombay blood group where blood is not easily available. So you can collect the blood from the patient and same patient and transfuse just before the surgery when you are anticipating blood loss. So it contains all. Can you please keep your this Zoom platforms on silent? Yes, thank you. So whole blood has got all the components. Usually it is not recommended to transfuse whole blood. It is no more recommended. Then there is packed RBCs. Each bag has got a hematocrit of 60% and approximately 200 milligrams of elemental iron. Volume I already told you 300 to 400 ml. So 200 milligrams of elemental iron. This you have to mug up. Then there is gamma irradiated blood, where we do destruction of donor T lymphocytes. It is usually done to prevent the graft versus host disease in immunocompromised and stem cell transplant patients. Then there is CMV antibody negative blood. We transfuse this blood in transplant patients and pregnant patients where the risk of complications is high if the patient gets infected with CMV. Then leukocyte depleted blood, it prevents leukocyte immunization in hematological malignancies. So whenever the patient is having any hematological malignancy, you give patient leukocyte depleted blood to that patient. Then there are washed RBCs. The RBCs are washed with normal saline to remove the donor serum, and it is used in IgA deficient patients and in patients with paroxysmal nocturnal hemoglobinuria. So after blood, we have the next component, platelet-rich plasma or PRPs, we commonly known as. So platelets are prepared by centrifuging the whole blood, which separates the platelet-rich plasma. And there are two, SDP and RDP. RDPs are random donor platelet concentrates and SDPs are single donor platelet concentrates. So random donor platelet concentrates contains about 60 ml of plasma in each bag. And it increases, one bag increases platelet count by 5,000 to 10,000. So sometimes you can get the value that one bag increases the value by 7,000. So it is a right option. So anywhere between 5,000 to 10,000, one RDP increases the platelet count by 5,000 to 10,000. And the survival of these platelets are usually 3 to 5 days at room temperature. And these platelet RDPs are not to be refrigerated, as platelets lose shape and release their granular contents once they are refrigerated. Now, for collecting single donor platelets, we do a procedure known as apheresis and is equivalent to 5 to 6 pool units. So they will increase your platelet count by anywhere between 30,000 to 50,000. And it contains 200 to 400 milliliters of plasma. So what is thrombocytopenia? Normal platelet count anywhere between 1.5 to 4 lakhs. So thrombocytopenia is anywhere less than 1.5 lakhs. So incidence, they can sometimes ask of mild thrombocytopenia is 15%, moderate is 5%, and severe is 1.5 respectively. This data is as per PROTECT trial, which was a large randomized trial of thromboprophylaxis in patients admitted to both medical and surgical ICUs. So in patients with thrombocytopenia, you have higher ICU mortality and longer duration of mechanical ventilation. So that is why it is important to know what is the reason behind thrombocytopenia, and you need to correct the thrombocytopenia. Platelet survival in circulation is approximately 7 to 10 days. We know this thing. 7 days we have read in during our physiology days. And one third of the platelets normally are sequestered in spleen. Absolute platelet count is important, but what is more important is declining trend. Declining trends give you evidence of serious clinical problem. So bleeding occurs when platelet count is less than 50,000 if you are doing any surgical procedure. And spontaneously bleeding, somewhere it is written less than 10,000, somewhere it is written less than 5,000. I have taken this data 5,000 from European journals. So, but you can mark anywhere if it is less than 10,000, there are risk of spontaneous bleeding, especially intracerebral hemorrhage. So guidelines also recommend that if platelet count is less than 10,000, you have to remember this figure, you need to transfuse patient with platelet, even if the patient is not bleeding, because there is risk of spontaneous cerebral hemorrhage. Clinical recognition of cause is vital as therapy depends on the etiology. Etiology of thrombocytopenia is very, very important because in certain conditions, I'll enumerate those conditions, you are not supposed to give platelet transfusions to the patient. This is very important. They will definitely ask you if any question on thrombocytopenia comes. So what are the common causes of thrombocytopenia in ICU? It could be either because of decreased production from bone marrow, increased destruction, or increased sequestration. Normally, I've told you one third of platelets are sequestered in spleen. So if there is increased sequestration, either because of splenomegaly or some spleen or liver disorder, you can have thrombocytopenia. Drug induced, there are certain drugs like heparin, S2 receptor blockers, GP2B3 inhibitors, certain kind of antibiotics and alcohol. All these are causes of thrombocytopenia. Then sepsis induced thrombocytopenia in cases of massive bleeding because of consumptive coagulopathy. And then thrombocytopenia associated with microangiopathic hemolytic anemia. So there are three causes of this: thrombotic, thrombocytopenic purpura, hemolytic uremic syndrome, HUS, and DIC. No, decision to transfuse platelets depend on so many factors. What is the absolute platelet count at that point of time? What is the risk of thrombosis? Is there any risk of hemorrhage, which depends on platelet function and whether the patient is going for any surgical procedure or not, presence of active bleeding, and if the patient is having active bleeding, what is the site and how much is the severity of bleeding, and what is the etiology of thrombocytopenia. So patient with TTP and HUS, platelet transfusion is contraindicated. You are not supposed to give platelets. So for TTP and HUS, the treatment requires plasmapheresis.